So for next speaker, I'd like to introduce Dr. Thân Văn Sỹ, which is talk about the result of port vein and hepatic vein embolization using intrajugular hepatic vein access compared with hepatic parenchyma access, please.
Okay, good afternoon, moderator, professors, and all colleagues. I'm Dr. Thân Văn Sỹ from Vietnamese University Hospital. In the next few minutes, I will show you our study title, comparing the results of simultaneous portal and hepatic vein embolizations using a transjugular approach with a transhepatic approach. Recently, portal and hepatic vein embolizations is growth in the interest and clinical applications because it's a new chance for liver preparations before surgery. It's safe and induce faster and greater hypertrophy than PV alone. And in this technique, we close both the portal inflow and the hepatic venous outflow of the liver. Until now, there are two main different techniques proposed for SVE. The first one is transhepatic approach, that's with percutaneous puncture through the liver parenchyma to the hepatic vein, followed by block deposition and glue injection. The second one is the transjugular approach, that's with indirect catechorization the hepatic vein via jugular veins, then blocks deposition without glue injection. Boris Gill and some other authors recommend using the transhepatic approach because it's more easier access to the hepatic vein and the possibility to occlude the venous collateral. But until now, little data comparing between these two approaches are currently available. So the aim of this study is to compare the safety, technical, and clinical outcomes of PVE and SVE via a transjugular approach with a transhepatic approach in SCC population. So during 3 years, we collected 62 SCC patients with small initial future liver remnant volume. All patients received a test to control the tumor, then a PV and SVE to induce liver hypertrophy, and after 3 weeks, we do a CT scan to calculate the liver volume and evaluate if patients suitable for liver resection. Here's the for the hepatic vein embolizations, we use the transjugular approach if the patients have no availability of windows for hepatic vein puncture through liver parenchyma, and use the transhepatic approach if patients have safety access to the hepatic vein via liver parenchyma. And here's firstly, we do portal vein embolizations mostly using the ipsilateral approach. And here's for hepatic embolizations, we use either transhepatic approach or transjugular approach. For example, in this case, we have safety access through the liver parenchyma to the hepatic vein, so we choose the transhepatic approach to embolize. And here's after PVE and after PV and SVE, the SVE was used block T2 combined with glue injection here. After that, after 3 weeks, the patients will receive a CT scan to calculate the volumetry. And here's the intra-operations image, which shows that the right lobe is collapsed and the left lobe is significant hypertrophy. 6 months follow-ups after liver extraction shows that the left lobe is good quality with no recurrent lesion. Another example, in these patients, because a big ACC in the right side, and we could not puncture to the hepatic vein through parenchyma, So the transjugular approach is the choice. And then we apply the right portal vein and right hepatic vein. After 3 weeks, here's before and after embolization, shows that the left side is very big. So the patient received a right hepatectomy. 1 month follow-ups, no recurrence were found, lesions were found. So we move to the results. Here's the population baseline. In all 62 patients, we have 13 patients use transjugular approach and 49 patients use transhepatic approach. And we can see here all the features almost the same between two groups before embolization. And moves to the safety and technical outcome, we found that the pain after embolizations and some other discomforts or complications almost the same between two groups, except the population's durations, procedure time is tend to longer in transjugular approach because for transjugular approach after embolized PVE, we need to move to the next and puncture to the jugular vein and sometimes to cauterize the hepatic veins via IVC is not easy. So that makes the procedure times is more longer. And about the volumetric data, in this table we can see in both groups, we obtain significant hypertrophy of the liver volume after embolizations compared to the baseline, and in both groups with the P less than 0.001. And when compared directly in both groups, we found that there's almost all features before and after almost similar between two groups, especially the hypertrophy rate. The median value is almost the same with P over 0.05, and our results is comparable with the results of the Delacos study. And about the surgical outcomes, again, you can see here all the features relate to surgical outcomes, the operation types, intraoperative bleeding, vascular injury, and all these complications, the rates, almost the same between two groups, unless the operation time is tend to more longer in transjugular approach. And until now, when looking for in the literature, we found only one this study that's compared directly between two groups. In this study, having 36 patients with 22 use the transhepatic approach and 14 using transjugular approach, and the conclusions that almost the same between two groups. So in conclusion, the simultaneous portal and hepatic vein embolizations is a safe technique and is inducing significant liver hypertrophy. The transjugular approach has similar safety, volumetric, clinical, and surgical outcomes when compared to the transhepatic approach. And the choice of which techniques depend on the operation expertise and also the anatomy and pathology features of the patient. So thank you.
Sorry, question. Very nice presentation. For the transjugular approach, why only plug and no glue, but transhepatic glue plus plug?
Yeah.
What's the reason?
Yeah, actually, until now, for all the study available in the literature, you only use the plug to apply the haptic vein without glue. Actually, I think we can use like Pacto or Cacto. We can using a plug to occlude the proximal part of haptic vein and inject glue for the distal. But until now, there no study do like that. So and just used for transheptic approach, because in some case we found that the venous collateral develop very fastly after plaque deposition. So and also we have access through the liver, and if we if we don't use the glue injection, maybe it's a very high risk of bleeding. So glue injections to close veno-venous collateral and to embolize the access route.